on digital therapeutics, AI, and virtual coaches with a focus on hospital at home. I am in fact joined by Johan Granabens from Salut Social, who will actually welcome us formally and will tell us a little bit about the interest of Catalonia and Barcelona in AI, artificial intelligence. Nevertheless, I want to just give us at the moment a feel for the general agenda. And before that, just to say a little bit about our ETL Innovation Initiative. Next slide, please, Mark. Indeed. So we're a group, an initiative who have been working for some 3-4 years. We've always been focused on innovation, and we've always focused on phased and staged approaches to digitization and to maturation. You can see from this slide, which we have adapted from colleagues in Intel, the way in which we've placed a focus on improving quality of life for patients and also ensuring that costs are well contained, but that we shift. And today we are all on this kind of journey from moving from hospital care towards particularly care in the community and especially care at home. You will find this particular image on our website. I would say that we will be making all the PowerPoints shortly available after the webinar, and eventually within a week or two, we will be making a short audio video available too. So Mark, next slide please, which is the agenda. So a brief overview. Johan will join and speak in a moment, and from sunny Barcelona. And we have 3 sets of presentations, 3 sets of speakers. You can see online at the moment, and indeed Johan has joined. He's the man directly below me on screen. Ed de Kluiver and Astrid van der Velde from Isla in Zwolle in the Netherlands will talk to us about their learning experiences in their hospital and the shift of their care from home. Riccardo Re and Massimo Caprino similarly, but from Milan in Italy. And then we will have a presentation from John Crawford of Crawford Works and an honorary ETL member. There are several other honorary members online with us here today as well, but John will tell us particularly about some examples of digital therapeutics and particularly how AI can help with that. We're hoping that we will have a Q&A and a chat at the end of the session. After every presentation, there will be a couple of minutes free to ask questions. And my colleague Tino Marti, maybe will you say hello, Tino? Yes, will handle for us any chat questions. So you can write, please write in the chat box if you have any questions for us, and Tino will collate and curate those and then feed them through into the conversation. Thanks for that. So welcome everybody, great to have you with us. Johan, please do tell us all about Salut Social and your interest in AI.
Hello, good morning everybody. It's a pleasure to be here. Thank you for inviting us as a Salut Social Foundation from Barcelona, from Catalonia. And it's very, very interesting, the topic that as a group we are talking. because we want to be involved in the in the deployment of the capacities of the artificial intelligence for health. For this reason, here in Catalonia, we started a specific program to try to deploy the artificial intelligence for the health sector. We understand that we have and we need several things to implement to deploy the artificial intelligence. In one hand, we need good data, and we think in Catalonia we have good data, especially medical image data. And in this case, we have a huge cloud infrastructure with all the image that has been done today in Catalonia in the public sector. So we have good data, clinical, medical, and image data. And also we have talent. So we have people who wants to improve the health sector and can plan new initiatives, new ways to improve the provision of the health. And at the end, what we need also is technology. We need infrastructure, we need IT experts and knowledge to deploy and to develop and to deploy all these capacities. So as European region, as always, as the most of you, we have the ingredients to plan a good approach to be effective on the capabilities of the data and the technology to improve the health sector. And for this reason, we are trying to plan a specific strategy to advance on this. And it's not, it's clear that we have main difficulties to do this plan. The main difficulty that we have at this moment, and you will be agree, is how to use this data from the public, but also from the private health research centers to deploy and to develop this artificial intelligence. So this is our interest today from Catalonia. We are very, very involved in this initiative, and we want to be there. And we are aware about the difficulties that we have from Europe to this field.
Thank you so much, Johan. Thank you for the introduction and expressing TIC Salud Social and Catalonia's keen interest. Let's therefore hear a little bit about the experiences of two of our colleagues. So Ed and Astrid, we will pass over to you to hear about what's been happening with NWE-Chance and the Isala Heart Center. Thank you.
Well, thank you very much for the introduction and for the invitation to speak to you. Good afternoon, ladies and gentlemen. My name is Astrid van der Velde, and I'm manager of the cardiology practice at Isala Heart Center. And Isala Heart Center is the largest non-academic heart center in the Netherlands. And we have profound experience with virtual care. And one of our examples is NWE-Chance. And I'm the project leader of NWE-Chance. And I'm here together with my colleague Ed de Kluiver. And Ed will introduce the topic to you and himself. So now I hand over the virtual mic to Ed de Kluiver.
Thank you, and also thank you for the possibility and opportunity to present the details about the NWE-Chance project. My name is Ed de Kluiver. I'm the chair of the Heart Center, Isala Heart Center in Zwolle. As said already, the largest non-academic heart center in the Netherlands. We have already, for almost 2 decades, experience in providing healthcare in the living environment of the patient. May I have the next slide, please? And the reason for that's, well, the most obvious and already known for decades, that there is a shift in the composition of our society, in aging people with limited finance and reduced hospital capacity to cope with the demanding healthcare requests. It's also known that on the patient level, that especially for the elderly, there is some hazard in hospital admissions. And we know that the elderly patients have a high chance on delirium, hospital infections, falling trauma, and in permanent physical and mental condition reduction. So these two main reasons were for us the drivers to investigate whether we could hospitalize patients at home. And we were helped by the developments in the technology, digital health, artificial intelligence. Actually, we started in the UMTS era when mobile broadband technology became available. So from that era off, we were finding solutions to really safely hospitalize patients at home. May I have the next slide, please? And as a very known football player in the Netherlands, he already died, Johan Cruyff, stated there's every disadvantage has an advantage. And what you see is that the corona pandemic stresses the need for hospital care at home, and there's it stimulates and induces all kinds of initiatives to hospitalize patients in their living environment. Because of the limited amount of beds, but also to reduce the risk for patients, especially the elderly, in hospitalizing them at home. So it's not only here, but also in China, that there is a vast impulse in digitizing digital care provision as a facility instead of projects. May I have the next slide, please? So after some experimenting, we started with a feasibility study in 2005. Actually, what we now call Virtual Heart Center was then the Chance at Home initiative. I will show you in the next slides. But the principle is that we have professionals on the distance and hospital care provided without concrete, using all kind of E&M health technologies, sensors on patients, and all kind of point of care technology. Next slide, please. So what we provide right now, so we started as a feasibility study, and in 2009, it became a real facility. And what we provide now is for mostly patients with heart failure, a 24/7 service, clinical admissions at home, supported by specialized nurses and e-health facilitated. And it's in a 30-kilometer radius around our hospital. Next slide, please. Up to now, we admitted over 1,000 patients at home. The mean age of the patients is around 80 years. So that's the vulnerable, really the vulnerable, fragile patients that we admit at home. The patients have all a significant higher satisfaction admitted at home than compared to the hospital admissions. We see that the most vulnerable patients benefit most, with a very low percentage of infections, no documented delirium, more active patients, and less falling accidents. And a nice conclusion is also that it's cheaper compared to hospital admissions. Next slide, please. But it's nice to have around 120 patients admitted every year, but we want to scale up, and scaling up requires some challenges. And the two challenges we have to encounter is that we actually build we provide not only a service, but actually we build a hospital outside the hospital. So every aspect of hospital care, technological, organizational, sales, purchasing department, every kind of detail that you have in the hospital, you also have to encounter in a home situation, except the building aspects. But every other aspect you have to deal with. So you have to build it, and for that we started a consortium to find and look for the solutions for scaling up. And there are two aspects that we especially deal with or have to deal with. That is building the professional organization with all kind of aspects that it is, and providing integrated technology, the platform, the connectivity in a multi-vendor environment. Next slide, please. So we started the NWE-Chance project that has to deal with these kinds of challenges, the technology and organizational challenges. And we are granted with an Interact grant as a support for this project. Next slide, please. We have three types of partners in this consortium. We have the technology partners, the SANANet, HC at Home, and Sensium. We have the clinical partners, Isla, Jessa Hospital, and Maastricht University Medical Center. And we have the knowledge partners, Digital Health and Care Institute, Ethel, and the University of Hasselt. And these 3 or 9 partners joined together. Next slide, please. With 3 major objectives: to develop a prototype hospitalization at home, so building the virtual hospital with all kind of organizational blueprints, to demonstrate that there is an integrated home hospitalization platform available for supporting the healthcare process, and to establish a sustainable innovation hub where all kind of participants working in this area can interact with each other and make their solutions visible to others. Next slide, please. Well, one of the challenges is, of course, the multi-vendor environment integrating into one platform. And this is an example of the different types of sensors and applications that we have to integrate. Next slide, please. So for take-home message is, well, we certainly conclude that hospital admissions at home have an added value. They are cheaper, but we certainly have to deal with some challenges. Building a solid virtual hospital organization, integrate all types of technology, not only the types of technology that we show now, but also the future technology, so it has to be sustainable. And the opportunities we have that digital health and artificial intelligence are rapidly developing and can support us in this voyage. So the hospitals of today are certainly not the hospitals of the future. Next slide, please. And these are our contacts. Thank you very much.
Ed, thank you so much, and Astrid too for the introduction, for filling us in on what's happening in NWE-Chance. I had some questions of my own, but I'm very happy to open up to the audience as a whole, the community as a whole, if people have questions. And my colleague Tino will handle those. I notice Gunnar and Stefan. Tino.
Yeah, maybe we can start with one question from Gunnar Klein related to the type of cardiology patients that you are currently treating at home.
Yeah, but actually the vast majority are well-assessed heart failure patients. So the diagnosis is already made. We do not need new examinations. So it's a chronic heart failure, and when there's an exacerbation of the heart failure, patients can be admitted at home. So we already know that. So that's one group. Another group of patients is a group with a low-risk myocardial infarction that we have performed the PCI on, and then we discharge it within 12 hours, and the rest of the hospitalization is at home. The third group of patients is actually a thoracic surgery patients with a pneumothorax that normally they would stay in the hospital for, and now we can discharge early. And the last group of patients is endocarditis, patients who need for over 6 weeks of antibiotics intravenously, and that we give the intravenous medication at home.
Thank you, Ed. Another question that is expressed by Stefan, but also by Diane, is in the offer of service at home, you are including only admissions at home, or also other sort of services that hospital provide, inpatient or outpatient, but can be delivered at home, like telemonitoring that doesn't require necessarily an hospitalization?
Yeah,
do you have this rate?
Yeah, beside the hospitalization at home. So the hospitalization at home can start inside, so on the cardiac emergency unit. It can be an early discharge inside from the hospital from already more or less stabilized patients, or the hospitalization can start at home on request of the general practitioner. At this time, there's no real telemonitoring because we want to test that with the Sensim patch in this project. We do have ambulatory telemonitoring, and we also have as a service ambulatory tele cardiac rehabilitation, and we also have home monitoring for patients having a device like a pacemaker and ICD. So actually, we have all aspects of hospital care, ambulatory, rehabilitation, clinical. We can provide at home. And the last study, that is for the acute patients with chest pain, we have rapid chest pain assessment with lab testing at home, and then we leave the patients at home.
Okay, thank you. An additional question, you show us a map, I guess it's the local surroundings of the hospital. Are you also treating patients out of your catchment area in other neighbor countries?
No, it's actually, well, it's more or less, we found out that a radius of 30 kilometers from a real concrete hospital is is practicable. Otherwise, it's the maximum is, say, 25 minutes drive from the hospital. That is what you can handle. Otherwise, it's the driving distance is too long. So, but we treat it as a module. So now one of our locations is 30 kilometers up northward, and we now preparing to start a second module of the Chance at Home, the home hospitalization, from that center.
Great, thank you. And in line with this, in terms of payment system, do you have incentives for home hospitalization? You are paid equally, like a regular inpatient care, or there are differences?
No, there are differences. What we have in the Netherlands is a DRG-like system, but it's not paid as a normal hospital admission. It's an add-on for ambulatory care. So it's a say it's a hospital at home day. On the normal DRG you get paid for, and that's but still covering the costs.
Thank you. And another specific question from Luke Nicholas related to the help desk. Which sort of concrete services are offered to patients or now?
The patients, actually we have one nurse starting early in the morning, and we have, well, on average around 6 patients admitted at home and making a round. And then it after at the end of the day the duty starts, and so the patients can call the nurse, but it's a nurse they met during the day, so they can call that nurse until the next morning for questions, but also sometimes it doesn't often happen, but sometimes it's necessary to visit in the evening or at night, and it rarely happens that you need an ambulance for acute services. I think it's in all those years it's only happened once or twice.
Perfect. Just new question from Frederic Nemeri. Are there any technical functional barriers like connection, Bluetooth, digital literacy for patients, and who takes care of these barriers?
Actually, all equipment is all equipment. There's no equipment that the patient has to take care of. So the nurse brings their own technology, their connections, etc., with them, and as we have a very good 4G coverage in the Netherlands, so that's not a problem. But it's also roaming, so we can use Wi-Fi. But actually, 4G is doing quite well. So and it's working two ways. Looking into the medical dossier that is in the hospital, but also sending data, ECG, etc., to the hospital, to the electronic patient record.
Okay, thank you. Maybe last question from Stefan, and we continue. Stefan says that Germany has established various models of telenursing, where the nurse connects while at the patient with a physician for assessment and therapy. Does this happen as well?
Not yet. In the ambulatory setting, we have, yeah, of course we have, and that's smartphone-based telemonitoring, and well, we're trying out all kinds of new sensors. But in the clinical setting, it's quite difficult to have, up until now, to have a reliable permanent monitoring system.
Perfect. Thank you very much, Ed, and to all participants for the questions.
As you can see, we're all on a journey together, and this journey is very much the linkage between treatments, hospital, home, and AI and digital therapeutics. You will observe that we will progress steadily, incrementally through those issues over each presentation. So we're very happy now to introduce Riccardo Re and Massimo Caprino, who are both from Milan and from the Casa Cura Policlinico. Thank you very much indeed. Welcome.
Okay, thank you, Diane. Thank you, the ETEL organization, for guesting us and for the possibility to showcase what we have done in the last years in the field of neurorehabilitation, what we have called until in the past telerehabilitation, and now how we are going to moving forward to the digital therapeutics. The presentation is split in two parts. The first one showing a little bit our history in digitalization, and the second part more wide on the VCare project, where I also encourage all the partners which are in the call to answer to the question which will be raised. I will start providing the word to from the field, from my colleague Ricardo Correa, which is a physiotherapist working on research, which he started on this experience some years ago. Ricardo?
Thank you, Massimo, and thank you all of you. Good afternoon. It's a pleasure for me to join this webinar. The current topic is very, very dear to me and to my work as a physiotherapist and as a researcher too. My speech will present firstly a path of a patient affected by a neurological event inside the ordinary healthcare system, and will put this process in strict relation with my personal walkthrough experience inside the Casa di Cura del Policlinico for an ideal development for a digital therapeutic solution. So please, next slide, please. Thank you. Now let's see which are the three main stages of the neurorehabilitation pathway. First, we have intensive care units where patients have the chance to stabilize their clinical condition after a severe brain injury, for example, a stroke. Secondarily, they move into the hospitals, into the rehabilitation centers, that is the case of Casa di Cura del Policlinico, where they could perform an attempt to restore their motor and cognitive impairments. And third, at the end of the process, if they have the possibility, they come back home. And this is the first critical moment. It's by now that we could say arise the need to have a available digital therapeutic solution able to solve and to cover at home the new needs of a patient. So which are these new challenges? At home, patient impact with motor impairment, with cognitive decline, with inability to perform by themselves of the activity of daily living. And so that the final result should be able to guarantee the reduction of disability and the enhancement of quality of life. So this is the biggest challenge. Please, next slide. Thank you. But to be prepared to pick up these new challenges, the journey of a digital therapeutics development process begin much more in advance. Here it is in CCP. We started from 8 years ago from a single experimentation on a commercial solution until trying to reach the final results. And this is a clinical evidence-based validation, in this case with the VCare project that will be presented later by my colleague Massimo. But in the middle, we have years and years of study. We have tons of hard working about trials, pilot tests, preliminary studies, RCT, that investigate many elements and issues of the process, like, for example, the safety of the solution, the accessibility, so the user friendliness of the digital therapeutic solution, the engagement of the patient, obviously the efficacy of the rehabilitation treatment, and most of all, the adherence to therapy in the transition process from hospital to home. And so that we can claim that digital therapeutics is manufactured in hospital, but it is enjoyed at home of the patient. So in conclusion, next slide, please. Thank you. These are the findings of innovation we found in our timeline, in our walkthrough, that should be the new challenges to adopt for a better continuity of care from hospital to home, something that is actually lacking of, at least in Italy. So first is the presence of effective rehabilitation approaches, and this I mean available and effective motor and cognitive intervention. Second, the presence of different clinical landscape. The neurorehabilitation is not enough. We need multiple clinical contexts in addition. So the cardiological one has seen in the previous presentation, the cardiological, pneumological side, also musculoskeletal side. Third, the presence of multiple intervention regarding quality of life. The taking charge is at 360 degrees. And so we need multi-professional skills, for example, competencies of nurses, competencies of in the medication support, in the behavioral support, in the risk management support, and so on. Fourth, the presence of an automated and customized pathway. And this is intended as the superior entity represented by artificial intelligence, by the virtual coaching in the case of WooCare, that is able to adapt and to customize the pathway. And last but not least, the presence of a sustainable solution conceptualized for this continued process. And sustainable, I mean economically, but also ecologically, intended as a non-intrusive system. And so, in conclusion, these are the requirements we are promising to achieve with WooCare project. And now with the next slide, I give you the word to my colleague Massimo for the second part of the presentation.
Okay, let's jump a little bit in the future. WooCare project, virtual coaching activities for rehabilitation in the elderly, is a research and innovation project financed within the European 2020, which works in this continuum of care between the hospital and home, where, as my colleague Ricardo said, the key points are the adherence to the care plan, which is provided at the discharge from the hospital, and the patient empowerment, so how to motivate the people. Next slide, please. Some key elements from the concept of the project, which starts from a clinical perspective. We're starting in development some clinical pathways according to some pathologies which affects the rehabilitation, the stroke, the Parkinson's disease, the heart attack, and the heart failure. First of all, we defined the patient characterization, which is provided by the hospital and the discharge, and then mapping the patient characterization to the pattern templates provided by the medical guidelines. We have identified some needs which could be fulfilled by existing technology or new services to be developed within the WooCare project. Next slide, please. As an example, the one from the stroke case, we have set up pathways according to the kind of stroke, ischemic of hemorrhagic, which we treat. We have identified which are clinical aspects which should be enhanced within the clinical pathway, like balance impairment, memory troubles, or pain. And then we have identified some services to be enhanced by existing technology, like physical therapy, the movement, cognitive training for memory retention, risk factor modification for falls, emotional rehabilitation, and pain management. And for each one of these, vCare system integrates or develop services in the sense of digital therapeutics, which could be provided to the patients. Next slide, please. These digital therapies are not standalone services, which anyway are part of the solutions and could be provided in a standalone mode, but vCare has the intention to enhance them through a layer of knowledge management based on semantic technologies and a contextualization based on the knowledge provided by sensor. In this sense, three aims of enhancement of the digital therapies are: the first one, the services which a virtual coach could provide to the patient at home in terms of feedbacks, in terms of reminders, in terms of information and education. The second layer is the personalization. The rehabilitation process is not a static process, but it depends on the performance which a patient can reach, which is easy to be monitored in a hospital setting, less easier in a home setting. That's a second purpose of the project. Thirdly, the pathway adaptation, according to which are the different services to be combined within the pathway according to the feedback which the patient will provide and the new indication which the physician will develop during the rehabilitation at home. Next slide, please. Here comes the artificial intelligence. From a very basic perspective, we can split in two different stages. The artificial intelligence driven by the rules, which are the rules which based on the behavior that the patient has shown in the clinic, interacting with technologies and are embedded in the clinical guidelines. But then, as the cycle of life of the different rehabilitation activities at home are performed, it comes the machine learning, which is enhanced by the data which are consumed by the platform. Next slide, please. Finally, we have set up a very long process of clinical validation. We are, let's say, at the beginning, but the process will last 22 months. From a technical perspective, this will be very useful because the data gathered will enrich the algorithm, hopefully to provide the virtual coaching features we have shown before. But from a clinical perspective, there's an enhancement in the involvement of a patient, which starts from a first phase of participatory design, where he's involved in a very soft way with dissemination materials, with like videos on leaflets, and then in the second stage of the living lab phase, he's directly experiences the system in a controlled environment inside the hospital. Basically, some kind of setting, replicating apartments where he can perform activity of ordinary life, will be set up in the different pilot centers, and he will experience the different use cases. And finally, as a clinical validation, he will perform the same activities at home with a real support of the virtual coach in a remote way. This will provide also useful hits for the certification of the solution towards the pre-commercial phase. Next slide, please. So this is the consortium. ETEL is part of the consortium. University of Dresden is coordinating the project. We have other clinical centers performing the piloting, like the University of Bucharest and Aarhus, and the Zakideka services, and some technological partners. Here are the components, and thank you very much for the attention.
Thank you, Massimo and Ricardo. I would start in reverse order. Instead of the first question, the last question, but we'll cover everyone input. The first is from Astrid van der Velde. The question is, how do you deal with patient disease-related elements that won't easily fit in a patient template?
Well, the pathway are well structured and are based on international guidelines. Of course, we cannot manage all the needs, and in this case, we have defined what we call exceptional procedures, where there are some engines which activate directly the support of the physician in the back end, in the back office, and we have foreseen also some ambulatory services to integrate the virtual pathway.
Perfect. Thank you, Massimo. Question from Stefan. It's open. He would love to hear a bit more, a concrete example of the journey, for instance, a mild stroke from treatment to rehabilitation. Maybe the question for Ricardo.
Yes, thank you, Tino. Yes, good question. An example could be seen as of a mild stroke that arrived from intensive care unit and start the rehabilitation inside the clinical pathway. But here will be presented the new technology of VuCare in order to cover and collect which are their needs. So it's something that could be adapted on a single evaluation for the characteristics of the patient. But it's fundamentally made of the motor rehabilitation made by the virtual reality, for example, or cognitive rehabilitation using motion sensor, able to stimulate also the cognitive activities and the movement of a patient who have an upper limb or lower limb impairment or balance too. So this journey is something that is strictly related with the normal clinical activity, but it's something that in advance will show at the patient the importance to continue these habits also when they will come back at home. So it's nothing so different from the normal clinical activities. They are not differentiated activities. This is a continuum for the clinical activity and for the transition to home.
Thank you, Ricardo. Question to both of you from Diane. How important for you in Milan are digital therapies or digital therapeutics, and how much will the system or the health services be based on machine learning and artificial intelligence?
I'll just say two numbers in our, which are financed by our regional system. Usually, a treatment in-house in our clinics is last 2 months, which are completely paid by the public, and then when the patient moves to home, usually the public services provides just few hours of therapies. So the need is huge. The point is how much to close the gap of this imbalance, and this is a topic which we still don't know the answer, but for sure this COVID situation will provide new strategies in order to close the gap. Concerning the machine learning, yeah, I honestly speaking, I think we should treat this point in a different call. We are not technicians. We expect a lot, but of course the expectation have to be proven. But in any case, I guess in 20 months of piloting, there is the time to get contact with, also by clinical people, with these new technologies and collect data and understand how much technologies can close the gap with the real coaching from a physiotherapist or clinician.
Okay. Thank you, Massimo. Last question, in fact, was the first one posed by Diane. How do you see the coverage of caring for people at home from the admissions stage, like what we heard from the Isala Health Center, to discharge and rehabilitation at home, like the example of Vicar?
So the process is something that is very smooth, and so in my opinion, the progression of the take care at home is something that starts in the hospital, but never end also then when the patient come back home. The most important thing is try to change the habits of a patient. So a good digital therapeutics should be able to persuade the user, the patient, to change a bad, unhealthy lifestyle, for example, in order to prevent the other kind of morbidity or a worsening of their condition. So the key element is to stay so close with the patient, and for that reason, it's very, very important the help of a knowledge layer of a virtual coaching, of a artificial intelligence algorithms, and something that is not clear to replace the physician, the physiotherapist, the nurses, but it is something strictly connected with their work. The patients should be safe at home because they change their needs at home. In hospital, they are I had a good adherence to the therapy, but when they come back home, they refuse the therapies. There are many distractions, and so the most critical and the greatest challenge, in my opinion, is try to solve this node. So how to improve the real adherence to therapy of a patient when he is at home. And so I think that should be very, very interesting question, but it's not an easy answer because it's very, very complex. Many aspects are involving in the take care at home. But fundamentally, this is the persuasion of the patient in a positive way. Persuasion.
Thank you, Ricardo. Last question from Live Apers. And related to the continuity of care that you stressed in your presentation, how do you match the digital therapies with informal caregivers of the family physician of the patient?
The caregivers are an important, very, very important element of the virtual coaching system, of a digital therapeutic solution. But it's not easy to involve because informal caregiver, so the parents of the patient, so relatives, are sometimes not so interested to be involved in many activities, but in the same time they want to be informed, and so the project would like to add a system of feedback, a system of a report that could inform the informal caregivers or the formal caregivers of the progression of their relatives, of the patient involved in the process, and so they could be safer to know if they, for example, are able to perform their motor rehabilitation. Are safe to know if they use the prescribed walking aid during the walking home, and so it's something that make them safe, but in the same time they don't want to be so involved. So don't forget to be that we don't have too much intrusiveness in the digital therapeutics, and this is a key element also for the caregivers.
Thank you very much, Ricardo and Massimo. We leave it from here for the next presentation, and I hand over to Diane to continue the session.
Massimo and Ricardo, thank you so much indeed for that really frontline and close to the patient and close to the people overview of the challenges of digital therapies. I think there were also some pending questions that we may come back to at the end. But really interesting to expand the conversation also to how it affects people surrounding the patient and the community. And indeed, now we're going to pass on to John. It's my pleasure to introduce John Crawford, who's going to be giving us quite a range of examples of digital therapeutics and what they have to offer and how AI helps. John, over to you. Thank you so much.
Thank you, Diane. Can you hear me okay?
Perfect, lovely.
Good, okay, just checking. So, well, first of all, thank you to Etel for the invitation to speak with you this afternoon. I know on the call there are very many good friends and ex-colleagues and others that I've worked with or been involved with over the years. You know, I have a long history with Etel going back to my time as a member representing IBM, and then also as vice president and president of the association for several years. So it really is a pleasure to be back with you and have the chance to speak. I've now retired from IBM, as you probably know, but I still keep very close to digital health through my own company, Crawford Works. And today I'm going to give some thoughts about what is seen to be a relatively new term, digital therapeutics, but which is actually quite an old idea, the idea that we can use software to drive health improvements directly. The term digital therapeutics, it's hard to know exactly where it arose, but certainly for the last 3 years, it's become very topical, I would say. Companies like McKinsey and PwC have been writing about it over that period. And it's now actually being formalized into a set of principles, which I'm going to tell you a little bit more about. A key thing about digital therapeutics right now is that with the COVID lockdown that we're experiencing in many countries, and with people having to seek health interventions at home, it's also a very topical way to provide access to services that might otherwise be really difficult to get at right now. In fact, when I was doing my research for this talk, I noted that the FDA in America have temporarily put in some new guidance allowing companies that have software that they claim to be digital therapeutics but have not been approved yet by the FDA to be used in the meantime. So they're basically saying this stuff is probably effective for things like, you know, schizophrenia, psychosis, other mental health issues, and therefore let's let people at it and use it with tentative approval until we get around to actually clarifying just how useful and safe it is. That's a very interesting move, I think. So with that, let's move to the next slide, Mark, because I want to talk about what these things are, because there is a lot of confusion about, you know, what a digital therapeutic actually is compared to other kinds of apps that we may be more used to. The reference for me is an organization called the Digital Therapeutics Alliance. So this is an industry association set up in 2017. It includes a mixture of pharma companies, medtech companies, and a lot of software developers have now joined it. So quite an interesting blend of different parts of the industry. And they've defined digital therapeutics as offerings that deliver evidence-based interventions, therapeutic interventions that health improving, that are driven by high-quality software programs to prevent, manage, or treat medical disorder. And they can be used independently or together with medications, together with devices, or even together with other coaching and therapies that involve people directly. And I would add a third thing to this, actually, which is becoming more apparent, that digital therapeutics also have the characteristic of being able to capture outcomes as they're being used. And I'll give some examples of those. So they're generating data about how effective the therapy is, even as the therapy is being delivered, and generating what is often called, certainly in the pharma sector, real-world evidence of effectiveness. So that's the definition, really, and I would say that it's a start, but it doesn't tell you the whole story. So let's go to the next slide, Mark, because if we go a little bit deeper down another layer, how can we tell the difference between what we're used to in terms of various classes of application or service or intervention compared to this new term? Well, if you look at the spectrum here, I've really described three ecosystems. On the left-hand side, we've got the wellness and support ecosystem. So that's products and services that capture, store, transmit health data. Typically, we don't need clinical evidence to be present to use these things. Typically, we don't need real-world outcomes, or they're not really looked for. And this is really, I guess, the world of health informatics, you could say. Basically ICT for healthcare, telehealth platforms, consumer health information, and so on. And of course, all the wellness and fitness things that we're used to seeing. So this is a very useful category, but it doesn't really give confidence that if you use it, is going to really change your health outcome in a fundamental way. The second ecosystem I've put there is diagnostic and monitoring, which is really the idea that we can measure and look for signals using diagnostic tools and monitoring approaches. And this is obviously, very specifically aimed at medical assessment, trying to look for danger signs, trying to look for improvements and recovery. But again, it's very much in the field of measuring rather than acting directly on health outcome. So where therapeutics come into play is that we're really looking for software-driven solutions that deliver the intervention itself. And they can be aimed at behavioral problems, mental health issues, physical diseases, and disorders. The key things, though, I want you to take note of are that you really need to, if you're going to claim that your solution is a therapeutic intervention, you need to have clinical evidence of some kind. The more, the better. We're talking really as high level as peer-reviewed randomized trials, and also real-world outcomes. You'll be able to show that what you are actually delivering is measurably better than, or at least as good as, if not better than, the alternative ways of delivering the same thing. So it requires a much higher standard of evidence to be accepted as a therapeutic intervention. So on to the next slide, Mark. Now, DTX, the organization I mentioned, have set out a set of core principles here, and there are 10 of them. You can read them for yourself, and so I won't take you through them right now. But the idea of the principles is to say to software developers and to clinical, device manufacturers and others that want to be developing these kind of therapeutics, we'd expect them to adhere to, most or all of these principles. And you can see the principles to do with things like prevention or treatment, to do with quality of software, to do with engaging people, as Massimo and Ricardo said, to do with using clinical evidence to justify them, to be ideally reviewed and cleared by regulatory bodies before they start to get into general use, and to collect and analyze real-world evidence or product performance data. So this is just a set of principles. It doesn't actually mean that if you meet all of these, you have a regulated software solution. That's still down to organizations like the FDA and EMA. And you might be interested to know that when I checked, the FDA, as of January, have actually only given approval to 3 digital therapeutics so far, 3 of them so far. Pear Therapeutics, who have a solution for substance use disorder. Natural Cycles, a Swedish company, who have a solution for birth control. And Apple, who got approval for the ECG app running on the Apple Watch Series 4 for detecting atrial fibrillation, although that seems to me to be more like a diagnostic than a therapy. But nevertheless, there's 3 of them have been approved. So we're still right at the start of the regulatory domain as far as that's concerned. So I wanted to take you quickly through a few examples of where we're seeing these devices and software-driven solutions. appearing. And I just want to be clear that I don't have any connection with any of these companies. I have no interest in them, financial or otherwise. So I've just picked a few which I thought were particularly interesting or quite advanced in what they're doing. First one is managing back pain, a company called Kaya Health, US company. And they're using basically a tablet, an iPad, to do coaching for self-management to help people who have lower back pain, which is quite a common chronic pain problem for many people as they get older. And they're using basically the camera in the tablet computer to measure the posture and the movement of the individuals doing the physiotherapy to improve their back pain, and to feed back to the user how well they're doing it, what they need to do to improve. This is a very good and, I guess, relatively simple example of how you can take something that would otherwise require a physiotherapist in the room or at the end of a camera and turn that into something that can be automated using AI, using a form of artificial intelligence in order to optimize the physiotherapy for the individual. So that's one example, a fairly simple one. Mark, the next slide, please. Another one which I came across last year when I was running a day on digital therapeutics at a conference in Denmark was from a Danish company called NWE-Rehab. And they've developed a very interesting general purpose platform for physiotherapy and rehab. And what they do is, I think, is really rather nice. They first of all have a screening assessment to see which people are likely to respond to this kind of therapeutic. You know, some people just won't want to use computers. They'll want to have an individual helping them with their therapy and rehab. But others will be more amenable and more able to do it. So there's a screening part of it. Then there's an exercise part where the programs are tailored based on perceived ability to perform the therapy at home, because these things are really very much geared at doing it at home on your own, or maybe with a few other people. Finally, the analysis part, which is basically the system allows you to look and see what's going on with the individual in real time, so that any things are not being done well or correctly can be corrected in real time, and therefore people are not wasting their time doing exercises or movements which really are just not helping the individual to rehabilitate. So there's lots of these coming on the market. This is quite a common category of digital therapeutics, I would say, and it's not surprising because it's quite an obvious use case. Mark, the next slide. Another one that's coming into play quite a lot is the use of particularly virtual reality, either on a screen or even better, fully immersive using a headset to provide a digital therapeutic to help with anxiety and psychosis. Now, this one here is from a project being run by Oxford University, so it's not a product yet. It's called Game Change VR. And what they've done is they've built 6 scenarios that people can be placed into with their consent, of course. They can do it using a screen or ideally a headset, a VR headset, that allows them to basically be in what might be for them a stressful situation using, as you can see, animations, and allows them to basically get used to the idea of being in that place and interacting and looking around and just getting comfortable, taking away some of the fear that they might otherwise have. And they have various scenarios with 5 levels of difficulty, and they've published some very nice papers already on how this can help people who have been diagnosed with various psychoses. Mark, the next one, please. Another one similar, very similar, is but done in a different way, is from a company, again a Danish company, who have developed an exposure therapy approach where they've taken high definition video cameras and they've actually filmed actors at 360 degrees in a real location. So this takes the animation even further, and actually you feel as if you're really in a real location. You can turn around and look all around, in this case the shop that you're in with this other customer. And again, the idea of it is that you can interact with these people, and depending on your interaction, you can even change the way the story goes. So you can actually change what happens when you have a conversation with the person, because the software behind it is going to change the storyline based on how you are reacting. So again, very interesting, a very good way of providing people who have anxiety disorders to get used to being in a public place. And I was thinking this is a very pertinent kind of use case if you think about what's going on with the COVID crisis. The number of people that are going to have to emerge from the safety of their homes and to go into these busy places again is going to, I think, lead to a pretty big demand in mental health services to help people cope with the anxiety that they will now have, that they may not have had before the crisis broke. So very, again, very topical and very relevant use of therapeutics. Mark, the next slide, please. Another one is looking at cognitive and behavioral disorders. And there's quite a lot of evidence that you can help a number of these disorders by using techniques that really come from the world of gaming. You know, basically playing games on a computer or a tablet or on a gaming machine. And we're talking here about the sorts of things that show up quite often in youngsters and teenagers, such as ADHD, you know, attention deficit disorders, major depressive disorders, and autism spectrum disorder. And there's a company that I picked out here called Akili, who produced this thing called Endeavor, which is basically designed to help for people with ADHD. By and large, it's children who have the major problem with them. And as I mentioned, the FDA has actually given discretion guidance to the company to release this for free to anybody that wants to use it for the next 3 months. So again, very interesting use case. Mark, the next slide, please. I want to finish the last example, which you maybe, if you were at the ETEL symposium in Barcelona in December, you may remember this one. At the time, I said this is an attempt to bring together a number of different technologies in one package. It's a continuous glucose monitor. It's also a dual chamber insulin and glucagon pump. It's also it incorporates AI-based services to monitor what's happening in someone's bloodstream and administer exactly the right dose and predict when to do it and how much to do it. And it's called the Beta Bionics iLet, and it's described as a bionic pancreas. I think this is a really good example of how to bring all these various technologies, medical devices, monitors, pumps, and software together in a package that really directly delivers a very clear benefit, because you're replacing the function of the pancreas with a bit of software. What's happened since then is that the FDA are so impressed with this device in the States that they've given it what's called breakthrough device designation in December, which means that it will now be accelerated through the approval process. So it will now be released, hopefully, before too long as a digital therapeutic in 2020, if all goes well. So Mark, the last slide. Just to finish, I just want to take the mythology out of AI a little bit. In the end, AI, although it has a lot of aspects, it just comes down to algorithms. It's really just about algorithms and how they work on data. And they're either rule-based or they are machine learning. And the ones that are, I guess, most interesting for us here when it comes to therapeutics are machine learning algorithms. The idea that we can be using a therapeutic that over time can be improved, can adapt itself to us, can learn what works for us and make these adjustments and fine-tunes for us as we go along. And I would say that if we use it appropriately, if we use it in that way, then we've got the potential to adjust therapies very specifically to the individual over time. The idea of personalized medicine, therefore, really becomes deliverable. So watch this space. I think we can expect to see many more examples of AI-based digital therapeutics. And expectations are high, but as I've said, we've only got 3 approved by the FDA. I'm not sure the EMA has approved any so far. I've not found any. But we need evidence, and because these are not just more applications to try, these are designed and should be seen as medical interventions which have evidence behind them. So I'll stop there and just wish you all a very safe time with the COVID crisis, and hope that you are well and continue to stay well. Thank you very much.
John, thank you so much for that overview and definition of digital therapeutics, and also for the very wide range of examples that you've shown to us in so many different fields of therapy. I will hand over to Tino because he's got a couple of quick questions that we have time for to come through, and Johan will then sum up towards 12:25, 13:25 or so.
Thank you.
Thank you, John. Let's start with the first question from Astrid van der Velde. The question is related to the role of health professionals, particularly doctors and nurses, in digital therapeutics. And I guess that the question is in terms of if they are the prescribers of the digital therapeutics or if they are not the prescribers, which are the role in both scenarios.
That's a good question. Well, my understanding is that it should not be necessary to prescribe these things. It should be possible for you as an individual, if you have the confidence to do it, to basically try these things for yourself, and knowing that they have some kind of regulatory approval to use them with confidence. However, I'd imagine that many doctors and clinicians will want to prescribe these things in the same way as they prescribe other treatments, again, if the evidence is there behind them. So I think it's going to be in two ways. It's either doctors will prescribe and say, given your psychosis, given your mental health issues, given your undiagnosed heart arrhythmia, I'm going to prescribe this thing for you to use, which should improve things. But already you can go and buy the Apple Watch rather, and have your own ECG on your wrist when you need it. So I don't think it's one or the other. I think it will be both prescription and people finding these things and using them if they feel they're going to be helpful.
Thank you, John. Straight question from Santiago from Salud Media. How do you trust artificial intelligence if you cannot understand it? It is not like following a decision tree.
Yeah, this is the perennial paradox of artificial intelligence, isn't it? Really, I mean, if it's a black box, how do you know what's going on inside it? I think this creates a lot of problems for people. The idea that if it's not understandable by humans, that we should probably not trust it. Many of the early examples of the use of AI, of course, have required that you're able to kind of track back to, why the system has come up with a particular recommendation or way of working. That's difficult to do in many cases, especially when you get into machine learning, where sometimes the machines are extracting features that we as humans wouldn't even be able to recognize. So it's a difficult one. All I can say on that is that I think there will be another more deep session on AI later in the webinar series, if I'm correct. But in the meantime, I think we just have to be cautious about how AI is being incorporated into these things, and understand that there's always going to be a degree of uncertainty about why the AI system is doing certain things. But so long as we have tested for safety and efficacy, that's the best we can do. It's the same kind of idea of I guess as why do some drugs work for some people and not for others? Often we don't know. Often it's kind of mysterious, but it's a fact. It's what happens. Why do some drugs help people and the same drugs will harm other people? So I put it in that same category of uncertainty. But I think we're just going to be cautious about putting too much faith into AI until we start to get more experience with it.
Thank you, John. Maybe the last question from Sophocles. There are a couple of them very straight to. Is the characterization of digital service as medical device with the CE mark necessary to become digital therapeutic solutions in Europe? And does this digital therapeutics approval opens the door for reimbursement from payers?
Yes, so on the first question, in general, of course, if you're claiming that your software can make direct health improvements, if that's what you claim is when you bring this thing to market, then of course the regulators will want to take a look at that and decide whether they want to endorse it or in some way certify that. But there'll still be a lot of people that will say, well, we've got digital therapeutics, which kind of conform to the DTX Alliance's core principles, the ones I showed very early in the presentation. And we believe that we conform to that. And even though it's not regulated by a local regulator, we still feel that we've done the right thing. So I guess the thing is that you have more confidence if it's been looked at by a regulator and given a stamp of approval. But I don't think it's necessarily going to be the case that you need to have it. That's my understanding at the moment. And the second question, does it open door for reimbursement? I hope so, because a lot of these companies are not doing this in order to just base their business model on advertising or click-throughs or whatever. They're doing it in order to generate revenue. So of course, I think if the DTX approval process, either from the DTX Alliance core principles or from the regulators, goes ahead as planned, then of course we should expect to see reimbursement the same way as we reimburse for medical devices or drugs.
Perfect. Thank you very much, John. Hand over to you, Diane.
Yeah, John, there are surely some challenges ahead of us. Thank you for beginning to explain those to us, and particularly focusing on the regulatory and the certification related issues. I'm going to hand over to Johan, who has a few words that he would like to say, but every encouragement to continuing this conversation as we go forward. Johan, over to you.
Okay, that was very interesting. I think that we have a great challenge with the artificial intelligence, and especially with the digital therapeutics, because of, as you said, John, it's a new way to proceed, and we have to see how the regulation, how the certification could help us to implement this good solution. So I think the evaluation and the certification of these kinds of projects or this kind of initiative is the main challenge that you have to afford from an European vision. So thank you very much for your approach. It was very, very interesting.
We will be sending you a feedback form to ask you how meaningful the webinar has been to you and what it's given to you. And we will, as part of that, ask you a number of questions. Had we had longer time, we would surely have been interested to find out more what's happening in your own country, your own region, or your own initiative, and what concrete experiences you have, for example, of digital therapeutics and AI. Although, of course, as several of the speakers, John especially, but also Massimo, Ricardo, and others have said, this is a slow process. Things have not been happening fast so far, but clearly in this new era of infectious diseases and the threat of COVID-19, things have often moved much more rapidly and swiftly towards regulation and legislation than has been the case in the past. We'd be really fascinated to carry on a conversation with you about what's happening with you and what you see the major benefits and the major challenges in this field. As John so kindly introduced, so next slide, Mark, we are having a series of webinars, not only on digital therapeutics and AI, which is most likely to occur in early September, the first half of September, but my colleagues have been putting together interesting other webinars, both on the European health data space. And what was interesting when John was talking particularly about real world data and use of AI and the importance of personalized medicine, I think one can really see a fit there with the work in the webinar that we're preparing on the European health data space. And last but not least, Tino and colleagues are really going to focus on what is a health data ecosystem and how those ecosystems can really support integrated care. Both of those webinars will be around the latter half of June, the last couple of weeks of June. More information, John, I like your expression, watch this space, by the way, but more information certainly on our Imagining 2029 program on our own website. You can see a couple of URLs, web pages there. But having thanked all the speakers for your great preparation, your very interesting slides, and the questions and discussions from all the community, I want to say a very final word of thanks to both the VCare project and NWE-Chance. So thank you very much for supporting us and helping to host those things. Looking forward to meeting you at our next webinar, and thanks to you all for all your fascinating questions and discussion.